is noon in Boston area, and it is 10 a.m. in Denver, and lots of other times, lots of other places around the world. And a particular shout out to Margot, who I think has the toughest virtual commute for our GLODERM meeting, because it is the middle of the night in Australia, and she is awake and has joined us. So we're certainly a particular shout out to her. So I wanted to thank all of you for joining us for what marks the very first virtual annual meeting of GLODERM. Claire and I are co-hosting, and hopefully you can see her with the beautiful artwork in the background. Claire, if you can give a little wave. I've temporarily muted everyone just so we don't have a lot of background noise. So just a few kind of welcoming points. First of all, welcome. We're really delighted that everyone could join us today. I think in particular to me, it was really important to still have this meeting, because in a time when there's a lot of kind of splintering and concern and fear, I think our communities are really important. And this is a community that's really important to me. And in particular, I think we've been shown over the last few weeks just how important global health is to all of us, and how important these networks are. So I just wanted to take a moment to say thank you for joining us. Thank you for taking a moment out of your busy day. I know that for everyone, it's kind of a time of chaos at the moment, but I think it's a really nice opportunity to come together and just have a moment to see each other and to interact, think about the things that we care about, and to strengthen our health systems, which is important in this day and age. So, oh, and we have another person from Australia as well. Thank you. So I just wanted to say my warmest of welcomes, and how very appreciative I am that everyone was able to join us. A few small housekeeping details. So as you'll see, I've temporarily muted everyone just so that there wouldn't be a lot of background noise. You have the ability to unmute yourself, and certainly please feel free to share your video if you would wish, so that people can see you. Alternatively, if you don't want to, that's completely fine. We are going to try to have our speakers share their video so that you can see them, and our panelists, so you can see them as they're talking. There is, if you will notice, a chat feature, which on my screen is on my lower right. I'm not sure if it's the same place for everyone. We are leaving the chat feature open to all, so that means that what you post will go to everyone unless you choose something different. And the idea there is that people, kind of like a normal chat room, people can see your questions and comments. If you do scroll to the top of the chat, you will see that I have uploaded our agenda and also the speaker bios as PDFs. So if you want to download those, you can just click on them and you'll have them. I've emailed them out as well. I'm not sure I've emailed out the speaker bios, but if you would like to see those, please feel free to use the Zoom feature to download those. Perfect. So I think that one other thing I wanted to say before we get started is that you will have, I know you've received a lot of emails from me in the last week, but one thing that we sent out just about an hour or two ago is our first ever GLOWDERM survey. The idea of this is to give us a chance of really understanding who's part of GLOWDERM and how we can best serve you and how we can best really build this community. It is IRB approved. And it is completely anonymous. So I have no way of knowing if you filled it out. Nothing in it is linked to your email. It also means I have no way of knowing if you didn't fill it out. But I would ask, it's only going to take about 5 or 10 minutes. So if there's a break between speakers and you want to fill it out while you're during the GLOWDERM meeting, we're very supportive of that. So please take a moment and fill out our survey. I think it will help us kind of join together in terms of what we're looking for from GLOWDERM. Claire, I'd like to hand it over to you for a couple of minutes before we move to our first speaker.
Yes, I'd just like to echo your welcome and to really congratulate everyone for rolling up your sleeves and getting on with this, and for coming along on this journey from how we just had this twinkle in our eye a couple of years ago to a growing community. And it's really encouraging to see. I'm getting so excited every time somebody else joins the call. We're out to 62, so that's great. So this is the first time we've done this, and thank you to Toby also, and to David for supporting us with the Zoom connection. I feel we've just, Esther and I have just had expert tutorage just in the last few minutes. So thank you so much for that. And I think we need to also thank our speakers in anticipation, but we'll do that subsequently. So Toby, Esther, I think that's all I need to say at the moment. And yeah, we'll crack on.
Great, excellent. Well, we are right on time, and so I'd like to turn it over to Eileen Chang, who is our first speaker, joining us from UCSF, and we're so delighted to have Eileen joining us to talk about scabies today. And Eileen, I apologize for the non-fancy introduction. I'm not sure I can handle all my screens at the same time, but I'm going to pass it over to you. Let me highlight your video. Oh, good, perfect. So
yeah, I unmuted myself.
That's great. Thank you. I'm going to mute myself.
Well, good morning, good evening, good afternoon. So thrilled to be here. Hopefully you can see my screen. Can folks nod so I know? Okay, cool. So over the next about 15 minutes, I'm really excited to talk to you about scabies as an example of dermatology at the big table. I had said I have no conflicts, but I realize I may have one. So I am on the steering committee for the International Alliance for the Control of Scabies. So I'm super invested in this topic. And I want to also take this opportunity to thank Dr. Claire Fuller for being gracious and sharing slides with me. So my objectives for us over the next while is to first describe how scabies got a seat at the big table. And then second, to highlight gains towards achieving scabies control. And this has been really exciting work that many GLODERM members have been a part of, and I'm really honored to share that all with you. So what is this, or who is this big table, or what is this big table that I'm referring to? It's in fact the WHO, the World Health Organization. And so here we see a list of the WHO's neglected tropical diseases, NTDs. And these are diseases that are primarily communicable diseases affecting tropical and subtropical world regions. They affect 14.5 billion people around the world, over 500 million children. They unfortunately preferentially affect the poorest of the poor and oftentimes don't lead to death, so not high mortality diseases, but have high morbidity, leading to disability, deformity, stigma, and also costing developing economies billions of dollars each year. And so we see here that scabies is proudly highlighted in red, and I'm looking forward to telling you about how scabies got on this list and where we've gone since then. So we're going to walk it back to July 2012, when the International League of Dermatological Societies, the ILDS, put together a skin summit. And one of the products of this summit was the Grand Challenges in Global Skin Health Initiative. One of the initiatives that came out of this was the International Alliance for the Control of Scabies, IACS. IACS is a global network of researchers, clinicians, and public health experts dedicated to improving the control of scabies. And I wasn't part of IACS during its early days, but when I look back, it seems to me that this work was basically harnessing a small group of folks who had this incredible dedication and willpower to push scabies. And they did this, push scabies as an NTD, and they did this through publications and strategic partnerships. And it was really this attack on all fronts. And I want to kind of show you how that was done. So the first thing that we had to do was describe how big is this problem. So it turns out there's over 200 million people around the world who suffer from scabies. And not surprisingly, there is an inequitable burden. So we see that across all countries. So in high income settings, we see this in institutional outbreaks. So that includes residential care facilities like nursing homes, assisted living facilities. We see this in prisons, jails. We see this in daycares and schools. In low and middle income countries, there's a high background prevalence of scabies, where up to even 40% of children can have scabies. In some communities, that number is way higher, adults and children having 60, 70% with scabies. And then there's a group I also don't want to fail to mention, and that's migrants. That's refugees, asylum seekers, internally displaced populations who are not traditionally captured in any of these prevalent studies. And we must not forget about them, because they certainly face an equitable burden when it comes to all sorts of diseases, including scabies. And we know that there's barriers to diagnosis and treatment in all of these settings. And the story with scabies is not just that you have this itchy skin disease. So as a result of this scratching that leads to microtrauma introducing bacteria into the skin, we have these severe downstream effects. as a result of Staph aureus and strep pyogenes, otherwise known as group A strep. So these sequelae can range from being localized in the skin, so that's impetigo, cellulitis, abscesses, but they can also progress to invasive complications like sepsis, which has mortality associated with that, as well as affecting kidneys and the heart. And the sort of kidney disease and heart disease is all mediated through group A strep. These scabies complications were published very nicely in this article that also introduced IACS. Along with this was this monumental study, the SHIFT study that GLODERM members, Margot Whitfield, proud and pivotal participants in, that demonstrated that MDA approaches, either with ivermectin or permethrin, are very effective in reducing the burden of scabies in a prevalent population. It turns out MD ivermectin was the most effective in reducing both scabies and impetigo. And so this was really strong data that built upon a foundation of knowledge we already had around MDA interventions, which came from Australia, Papua New Guinea, Solomon Islands, and Panama. And it turns out that MD ivermectin is effective for many diseases aside from scabies, and we've recognized an opportunity here. So if we're already trying to tackle onchocerciasis and lymphatic filariasis through community control measures, that is mass drug administration of ivermectin, we have an opportunity here to also look at scabies and other ectoparasitic burden. We knew that anecdotally, there were reports from these larger programs, these onco and LF programs, that there was reduced itching, but no one had really looked at scabies as a specific off-target disease measure. Along with this was also a parallel movement to bring this notion of skin NTDs. So taking a step back, many NTDs have skin manifestations, but there are a number of them that primarily manifest with skin manifestations. So that's as pictured here: Buruli ulcer, leprosy, mycetoma, chromoblastomycosis, lymphatic filariasis, leash, not pictured here, so on and so forth. And we recognize that scabies also fit into this paradigm because as a disease primarily affecting disadvantaged and vulnerable populations, also contributes to disability and stigma. And so we kind of brought scabies into the skin NTD fold, as it were. And so a lot of these skin NTDs have overlapping clinical manifestations. So an example here would be ulcerative lesions caused by skin NTDs. This could be a result of many different diagnoses. I want to just also do another GLODERM shout out. A lot of members here are also working in this area. I think Rigatsu's on this call, and she does phenomenal work around Buruli ulcer and leprosy. And so I was mentioning how we'd sort of brought scabies into this larger skin NTD fold. And I want to just take a moment to talk about this approach of integration of skin NTDs. And so if you think about it, we're training these large teams, or they're not that large, sometimes just one person, but we're training these teams to go out into the field to detect these cases and based on exam of the skin. So why not harness all of that, those resources, that time, that energy to teach about many different skin diseases, maybe all the skin NTDs, including scabies. And as our thinking about this has evolved, we've also recognized that we need to also integrate training around common skin diseases that may not be NTDs, so like eczema, fungal, other sort of superficial fungal infections, because that's what our frontline workers are seeing. But this is an approach that allows us to really make the most of the resources that we have while still capturing data around scabies and other skin NTDs. Along with work that was happening in low and middle income countries, there was also increasing publications in high income countries, specifically around residential care home outbreaks. So with this dossier of data, we are able to make a compelling and convincing argument to the WHO. And in 2017, scabies was recognized as a neglected tropical disease. And it is a unique NTD in that it also affects high income settings. And we're strategizing and thinking about how we leverage that to push this agenda forward. So let me now talk a little bit about the the progress we've made since June 2017. So a very pivotal moment was getting this consensus diagnostic criteria out there. And the reason why this is important is because we needed a common language to talk about scabies. I think we all had like a gestalt of what we mean by that, but when you're trying to capture that data through epidemiology, through public health work, through research, we have to be sure that we're talking consistently about the same disease. Now, of course, a challenge with scabies that makes it different from many other infectious diseases and other NTDs is that there is not a reliable, sensitive diagnostic test. And so until that's developed, we have to have consensus clinical criteria. And we need to have that criteria such that those in the field who don't have access to microscopy, dermoscopy, that they can feel confident in making this diagnosis. And through a Delphi process of dermatologists and ID physicians, we were able to come up with this, publish these criteria. And then there was this WHO manual that was published around training frontline providers how to recognize changes in the skin as signs of NTDs. And this was work that many GLODERM members contributed to. Very long list I'm not going to go through, but we should be really proud of that. And then we're so thrilled that we were able to have a WHO informal consultation on framework for scabies control. And this was really critical because we were starting to develop some level of evidence through research about how we should be approaching mapping, prevalence. When is MDA important? But we needed guidance from our international public health body in setting these guidelines. So as a result of this meeting, we got some of that guidance. We now have some baseline idea of when it's appropriate to use MDA, although that will change likely as we do more research. And then also, very importantly, we identified key questions that we need to ask and answer from a research standpoint and from programmatic operational aspects. So the WHO puts out an essential medicines list every 2 years. And this, in order to get a medication on this list, it goes through a very rigorous process of adjudication and screening. And we're really thrilled that ivermectin was put on this list specifically for ectoparasitic infections. And this work was led by 2 dermatologists, part of GLODERM, as well, Olivier Chassedow and Rod Hay. This was an incredible amount of work, and it's really important because low and middle income countries look to this EML to decide what medications they're going to cover for their citizens. And so having ivermectin as a specific indication for ectoparasitic infections is really crucial. It doesn't mean it's definitely going to be covered, but at least there's some push at a higher level that government should be covering it. And I just want to take you through a few more publications, basically to make the point that we really focused on getting scabies out there into high impact journals. I will draw attention to this article that was incredibly important because it finally called out ill-founded safety concerns about ivermectin use in older folks. So this came from a methodologically flawed 1997 Lancet study that I often hear dermatologists still today say to me, this is the reason why they don't use ivermectin in older folks. And as a result of this study, many people who need ivermectin are not getting it. And this editorial really called that out and asked the Lancet to try to correct that wrong. And then just last month, we further kind of clarified the consensus criteria. We didn't change the actual criteria, but there was a lot of questions around, well, what exactly is a typical lesion? What's an atypical lesion? What's a typical distribution? What's an atypical distribution? And so these criteria really sought to give a lot of images, provide some schematics, and also clarify characterize what the itch of scabies is like, as well as define who close contacts are. And of course, really, really, truly exciting news. This $10 million grant for the Macquarie Group Foundation that was awarded to the Murdoch Children's Research Institute in Australia to eliminate scabies from Fiji and the Solomon Islands. And we're so thrilled for Margot and her team as they embark on this huge, huge, huge accomplishment. So yes, we'll clap, yeah. So up until this point, I've talked about key publications that really put scabies on the map, put it out there. I also talked about this clearly strategic partnership to have a channel of communication with WHO. And I just want to take a moment to acknowledge a few other important partnerships. So that includes the Neglected Tropical Disease NGO network. Through Claire Fuller's leadership, we now have a skin NTD cross-cutting group. Other GLODERM members are also a part of this group. And this serves as a resource for the WHO. And so now we have IACS and the skin NTD cross-cutting group pushing the scabies agenda with the WHO. And then more broadly speaking, in the operational research realm of NTDs, there's the Coalition for Operational Research on NTDs that meets every year before the American Society of Tropical Medicine and Hygiene meeting. We now have a scabies presence there and a skin NTD session each year, and we're really grateful for that support. And this allows us to network with program implementers, funders. So most of the NTD work is funded by the Bill and Melinda Gates Foundation, USAID, and UK Aid, and their folks and reps are there. So this has been a really strategic meeting for us. And then more broadly, we've had targeted symposium at the ASTMH. Over the past few years, a lot of this work has been spearheaded by Scott Norton, and we hope this year to have 2 more sessions. Fingers crossed that we can actually have that meeting in the fall. This is my penultimate slide, and I've kind of just laid out the different areas that I think are important for us to ask research questions around, as well as some key programmatic issues. And while you are kind of perusing what I've listed here, I wanted to just end by a patient story that's really stuck with me over the past few months. So in February, I met this 15-month-old infant who was admitted for failure to thrive. She had been 14 pounds for the past 6 months. When she was admitted, she was at 0.1 percentile for weight. And she'd had this itchy rash for a year. It began when she was still living in Guatemala. Mom had been told that it might be a milk allergy, so had been avoiding giving milk. And then of course got the infamous combined topical therapy of clotrimazole, a topical steroid, and gentamicin, which sort of helped with symptoms, but clearly didn't address the underlying problem here. So when they got to the US, they secured the correct diagnosis of scabies and were given permethrin cream. It's not clear where the communication breakdown occurred, but mom had been using it as spot treatment for lesions, as well as for this patient and the patient's sibling who had a similar itchy rash. Well, thankfully the patient was admitted for many different reasons, but we got the scabies diagnosis and treatment under control, and now scabies is treated, baby is gaining weight. But my point of bringing up this clinical case is that I think it really shows us the work that we need to do, right? We have the tools to diagnose and treat scabies, but we're not doing it for all the populations who need it, and they're being severely affected. We're talking about babies, kids, families, communities all around the world who are suffering needlessly, but we really have the skill set and the power, and I really think the drive to change this. So with that, I hope that you will join us in trying to make scabies, if not eliminated, controlled from the world. That's all.
Amazing. Thank you so much, Eileen. We can all give Eileen some virtual applause. That is fantastic. I really enjoyed that. Yeah, it's just so interesting and amazing to think about how much has been accomplished in the last few years. That's really wonderful. And congratulations to Margot on that, on the large kind of funding opportunity. So it's really fantastic. I wanted to give everyone the opportunity, if you have questions for Eileen. Thank you, Eileen. That was really wonderful. To either unmute yourself, unless we have like a battle of the unmutes, or if you want to just tell us that you're that you want to ask a question in our chat feature, you can also just type it right into our chat feature.
So it's lovely to have those lovely chats coming down the side there. And obviously, Eileen, you're a bit of a key star performer there. Ree, I just wondered, you are the only GLODERM member that was in the Philippines. and also at the core NTD, part of that Skin Cross, the meeting most recently. Is there anything you'd like to share with GLODERM members about what those meetings were like and how effective they were? Sorry, I've completely put you on the spot, but I wondered if you could.
You did. Yeah, I was not thinking I will be directed, but yeah. So yes, all the meeting has been interesting in that Scabies is also put in the spot due to all the work you've been doing with IADS. And like Eileen said, that Scabies is a part of NTDs, skin NTDs, but it's unique in a way that they are also, in the developing countries also, developed countries are also affected. And so we kind of, even in the Philippines, we kind of have struggle how to address that, not just the developing countries, but also the developed country, and also the high-risk population and the migrant populations. So this discussion is still coming, and so we are aware of the different challenges we have for scabies. So, but it has been a little difficult how to gather all the things together and discuss in one meeting. So that's the challenge I think we felt during this meeting, informal meeting in Manila. Another things are that, of course, the discussion around MDA for scabies is coming, but we also don't know, okay, where we should implement this strategy and things, and also if we will be able to get the funding for the scabies because of such a large population that we need to cover. So those that was also another big challenge that were discussed. And I think these kind of challenge we need to work together as like this group, because we have many expertise and things, and to work with the WHO, to work with pharmaceutical companies, to work with other dermatologists. So I think I think this the presentation was very timely to have during this Global Derm session.
Thanks very much. Thank you. Thanks so much.
And it looks like we have a question from Valeska to Eileen about point of care diagnostic testing.
Oh, yeah. Well, so currently there's not a reliable, sensitive diagnostic test for scabies, though there recently was a publication around a PCR diagnostic test, but the sensitivity is quite low. I don't actually, there may be others on this call who are actually more familiar with that test and maybe have even used it, but the conclusion of the authors from their analysis is that in the setting of an outbreak, let's say an institution where they could test multiple people, and if one person were positive, that would have implications for treatment of everyone potentially, that in that setting, that their diagnostic PCR test could be useful. But on an individual basis, we don't yet have a PCR or sort of point of care test, and we're really using clinical criteria. Obviously, if you're lucky and you happen to capture that mite, then you can feel really confident. But as we know, it's very difficult, right? When in classic scabies, there's 10 to 15 mites on the body to really get your mite. And so we're sort of left with using the clinical criteria.
All right, that's very interesting and challenging. I'm thinking, like, we can't really test for poop, can we? All right, now that is really helpful. Well, thank you so much, Eileen. We really appreciate it, and especially everyone for kind of rearranging your schedule and making this work. But what a beautiful presentation. Thank you so much. We're going to pass it on to Claire just to introduce Julia, who's our next speaker. But I do want to take the opportunity in the chat box. We're so lucky to have so many people from around the world. So if you are in a country other than the US, if you'd be willing to use the chat box and just tell us where you are, we would really appreciate it. And we get a sense of, what country you're joining us from. We'll really get a sense of our international audience. Claire, I'm going to pass it over to you to introduce Julia, who's our next speaker.
Yes, that's a great pleasure for me. So Dr. Julia Schofield is joining us from the UK. She is a consultant dermatologist. She is an MBE, which means the Queen thinks she's fab. So she's very well recognised in the UK for what she's contributed to dermatology here. She's an educator. She is a researcher. One of the most amazing achievements, although she's got many, was to produce the UK Dermatological Needs Assessment, which was an amazing piece of work demonstrating how underprovided we are for dermatology in the UK. But she's also a global health fanatic as well, and has sneaked out to Tanzania on a couple of occasions. And with her colleague and sidekick, they're Batman and Robin, I don't know which way around they are, but with Rebecca Penzer-Hicks, they are amazing educators and educate in a multidisciplinary fashion in a diploma of dermatology at Hertfordshire University in the UK. But what they've been doing in Africa is working to develop a nursing curriculum a specialist nursing curriculum for nurses in Africa, with the view of opening this up as a program that could be delivered in any country. So we look forward to hearing what you've got to say, Julia, and thank you so much for embracing this new way of working. Over to you.
Thank you very much, Claire. Can you all hear me? Is that okay? Yeah, fine. Thank you very much for that lovely, kind introduction. And this is something that is completely different from the previous session, and is really a collection of thoughts. And I'm very grateful that Rebecca Penzer-Hicks can join me. She's my senior lecturer colleague at the University of Hertfordshire. A very experienced dermatology clinical nurse specialist, and also the current chair of the British Dermatological Nursing Group. So I'm going to do my presentation and then ask her just to add a few thoughts at the end of the talk. So just to really reinforce what Claire has already said to you, basically, we work in the UK and we have set up a master's programme in dermatology at the University of Hertfordshire. It is run by myself, my colleague Rebecca, and another dermatology nurse specialist called Kathy Radley. So basically, we're busy practicing clinicians working in the UK Health Service, but we have set up a programme, an educational programme. And the key thing about this programme is that we teach nurses, doctors, pharmacists, podiatrists all together in the same room, which is what makes it different from other educational programmes. So what I'm going to do is just set the scene. Really, I think before talking, Rebecca and I reflected a lot on what Claire wanted us to talk about. And actually, we're going back to the beginning. I'm going to set the scene and just tell you how we have just transformed the role of nurses in dermatology in the UK, how that's impacted on service delivery, and the fact that this really means that we must link the needs of what the service requires. And it's going back to the work that I did on the needs assessment, which is that we need to look first at what are the needs and then look at the training that might be required to deliver on those needs. And that's how we started out in the UK, and that's how we're now looking to think about nurse programmes for Africa. So in the UK, as you know, we're a publicly funded health service, and we have waiting lists, we have workforce challenges. And what has become clear is the massive increase in demand for care of people with skin conditions. And this led in the UK to enormous workforce challenges. We don't have enough dermatologists and not enough people to see the patients. So in the early 2000s, following on from the Blair government and the NHS plan, there was a move towards developing what we call extended role practitioners. And these would be nurses, they might be general practitioners, primary care clinicians, who actually wanted to do a bit more or to extend what they were already doing. And we started to have this very strong view within the NHS that doctors should only do what only we need to do. So in other words, if you trained a consultant dermatologist, you should challenge a consultant dermatologist about what they're doing. So for example, should they be doing operating if actually we can train somebody else to do the skin surgery? So that's where we were in the early 2000s in the UK. So we started to develop our dermatology nursing roles, and the early roles many of you will recognise were very much around delivering phototherapy, inpatient treatments when we had beds, patch testing and management of chronic wounds such as leg ulcers. However, by 2018, Rebecca and her team at the BDNG had done a survey on what sorts of roles did UK dermatologists have. So we had gone from, I suppose, in the late 1990s, where basically Rebecca will remember the days when the nurse made the cup of tea and brought the bun into the middle of the clinic and didn't really do much else. We'd moved from that time to when actually we couldn't manage without dermatology nurses doing a range of roles. And I'm just going to highlight a few of them which have been pivotal in improving care and access to services in the UK. So we started out by thinking, well, really, our nurses could certainly support patients in terms of explanations around treatments and concordance with care. That was the early days. Wound care was really big quite early on, and our other colleague at the university, Madeline Flanagan, runs a master's programme in tissue viability. So nurses were moving into this area. I suppose in the 2006, it would have been, I decided I was a bit cheesed off with teaching nurses and doctors separately to do skin surgery. So we started to train them together to do skin surgery and to manage skin cancer. And we now have skin surgeons and skin cancer specialist nurses all around the UK in every department. And with a change in the law and the legal frameworks around drug prescribing, nurses became able to prescribe medications. So the most recent and the most enormous development that we've had is that they can do systemic drug monitoring and oversee patients on biological therapies. And there are a range of other things that you can see there, eczema management and a lot of other roles that they've developed which have responded to the needs that we had. So what were the enablers to this? Because if we need to look at those when we're going to look at developing programs elsewhere. So we had the government that had set up these initiatives to encourage extended roles. We had the legislation to facilitate non-medical prescribing, which was pivotal in developing these roles. And we also had a range of national standards that actually said that specialist nurses could deliver on a lot of these roles very effectively. And the British Dermatological Nursing Group, of which Rebecca is chair, was set up, I think, in 1989 and has consolidated the role by developing a range of educational resources and a political lobbying organisation for the role of dermatology nurses within the UK. The other major enabler, we believe, was the development of our multi-professional programme at the University of Hertfordshire. So we set this up in about 2006, and basically we have mapped this very much to the needs of the service, the dermatology service and skincare for people within the UK. And essentially, as I've already mentioned, we teach doctors, nurses and pharmacists together. People can study part-time or full-time, so many of our students will come and do a part-time study. They can complete their study over a prolonged period, over 5 years. They can exit with a certificate, a diploma or the full master's programme. We started out with skin surgery. We then have done skin lesions, dermoscopy, and then a range of modules that relate to the inflammatory conditions. And this is just a picture of our group, which is to remind me to tell you that in addition to UK students, we now offer places for full-time overseas students as well from all over the world. So with this background, Claire asked Rebecca and I to think about how we could take our experience and think about it in the context of African nurses. So Rebecca and I had a visit to the RDTC in Moshi in 2017. We went there absolutely confident that we would be able to set up an educational program. We designed the curriculum. I think we even had some dates in our diary of when we thought we might be able to deliver this educational program. We had taken an earlier KCMC nursing curriculum, and Rebecca had done a fair bit of work on it to modify it and make it what we thought would be good, up to date and deliverable. We spent a week there and we met all the key players. Now, I remember very vividly Rebecca saying to me towards the middle of the week that she didn't think our curriculum was going to work, and we weren't necessarily on the right track with what we were trying to do. And this was for a variety of reasons. I'll just go back one. This was for a variety of reasons. It wasn't because of a lack of enthusiasm. It was very much around the fact that we hadn't done this critical piece of work, which was about looking at what was needed in terms of a nursing service there. We were taking our curriculum of what we thought we should teach to an environment where actually that learning might not have been relevant. So we came away and we prepared a report for Claire, and we've got some key features that we think are relevant. It's obvious that you need full engagement from your medical staff. And I say that we have a lot of enthusiasm in Africa from the medical staff. But I think that is absolutely pivotal if you're going to take forward any program. But much more importantly, you need to look at the service that is being delivered and the roles that can improve that service, and you must link it to the common diseases that are being seen. So this presentation is really timely, because actually we went out there to teach about certain diseases, but the reality is it's probably scabies that is the most important thing that we might be teaching about, or similar neglected tropical diseases. But the other fundamental thing is that we have to take account of the nursing skills that are there that can be developed. And if there are none, then we cannot develop them. So we have to look at what have we got and how can we develop it. And ideally, you would have a nursing role model involved in any training opportunity. So we felt after our visit that there were tremendous opportunities to upskill nurses and develop nursing roles. We also felt that it would be really quite straightforward to deliver the classroom teaching programme in Moshi that we had thought about. However, in the absence of specialist nurses working in the clinic or on the wards, delivering practical dermatological roles, the required practical skills training would not be possible. So in other words, there weren't the nurses there for us to get practical training to support the classroom teaching. And the other problem that we had is, although the matron in the outpatient area is very enthusiastic, she was very busy with a range of important managerial duties, and there was clearly quite a shortage of nurses at KCMC, which meant that actually for them to take time out for education and training, it might not have been possible. So we left with a very different view to what we went with. And I suppose the most important thing that we came away thinking about was that actually in the UK, we know what we want in terms of our nursing workforce. We know we have an epidemic of skin cancer, so we've developed courses to support skin surgeons. We know that we've got lots of new complex second-line treatments to keep people out of hospital, and non-medical prescribing has helped to manage that caseload. So the question is, what in Africa and other countries are the needs, and what are the skill sets that we need to develop? And I don't know that, because although I'm very interested in global dermatology, I've not been around long enough, and I don't know the answers to these questions. But a couple of examples came to mind over the last few days when Rebecca and I were talking about this. And in actual fact, it's about basic skin health for a lot of these areas. So teaching people about complicated things is probably much less important than dealing with the basics. Scabies is another good example that we would need to teach about. And the other thing that struck us when we were at the RDTC was that actually there are a lot of chronic wounds, and tissue viability training might actually be really very important to try and improve patient outcomes with that. And there's probably many others that this group would come up with. So I suppose the point is that Rebecca and I are delighted to teach and to develop a programme, but we feel very conscious that it needs to be developed in the context of the diseases and the skin conditions that are out there and the resources that are to develop. So in summary, our UK experience over the last 20 years has shown that with the right drivers and enablers, nurses can make a huge difference to patient outcomes and patient care and patient experience. But what's crucial is that we develop nurse development to the service need. We'll need to develop different programs and different solutions potentially in different places. And essentially we need to ask the question and think about what do we need, where, and who is best to deliver the care, and only then develop the curriculum. But we do need some nursing role models, I think, and they are really important wherever we decide to set up any educational programs. So thank you very much for listening. I'll just tell you about the picture on the left, which is our red arrows. I'm up in Lincolnshire, and we have the red arrows up here, who are our national Air Force team that do these aerobatic displays. So I'm very fortunate often in my house here that they fly over on a Monday doing their practice. So I've just put that picture in there. And if any of you are interested in any of our courses, then our email addresses are there. Thank you very much.
Thank you, Julia. Thank you so much, and that was absolutely wonderful. And I think you've sort of so graciously shared with us that sometimes when you set out to do something, you sort of almost generate more questions than answers. And just to kind of encourage you, a group of nurses from Moi in Kenya came down to the RDTC CME meeting this year with what they called a carry-on call to encourage us to develop a nurse training curriculum and course somewhere in Africa to support them, because they felt there was nowhere for them to go. So I think we've demonstrated enthusiasm. I just wondered whether any of those who work in Kenya wanted to share their experiences at all with the group. Maybe Toby or Eileen might want to share their experiences from Moi with lymphedema.
I guess I'll get started, and Toby, please feel free to chime in. I just want to say I think that this topic, thank you for this talk. I think this is a really important topic and brings up a lot of potentially contentious and challenging topics to think about, but it's the conversations we need to be having. I'll just tell you briefly about our experience collaborating with the nurses at Moi Teaching and Referral Hospital in Eldoret, Kenya. We really became connected to nursing through wound care and lymphedema work that began at this point 4 or 5 years ago. And we were really fortunate in that the deputy nursing officer for the entire hospital has a vested interest in wound care. And so that really helped forge that relationship. And then from there, we now have a narrowband UVB unit at Moi. And so I think in those two areas, both wound care and phototherapy, for this particular hospital and this site, that turns out to be where the big nursing needs are. I'm sure there are many others, but for us, at least as dermatology collaborators, that's where we have been focusing our time and energy. And a lot of the things that you brought up that you observed at RDTC are very similar at Moi. So there's challenges around the way that nurses staff different clinics is different certainly from what I sort of have experienced in the US, and getting around those challenges. They're often not just dedicated to one area. They have multiple other things that they're doing simultaneously. And so we've really tried to restructure things to say, can we have dedicated nurses for this service? But that presents a big challenge for the administration, and it's a different model from what they're used to.
Can I make a couple of comments, Julia, if that's okay? I mean, I think there are a couple of things that really are shouting at me from what we've just discussed. One is that I think a really good starting point when you're looking at training nurses, and Eileen, the comments you've made are exactly this, is that you start training on a couple of key skill areas. You don't start by introducing a full curriculum. And actually we did this in the UK. The course in University of Hertfordshire started off by teaching about a couple of key core subject areas that were useful for people. Nurses are practical. They want to develop skills. They want the underpinning knowledge. But I think if we can identify some skill-based areas that we start with, so you mentioned lymphedema and wound management, UVB therapy, that is a really powerful way to start, and then that grows. You get interest, you get people enthused, and you can build on that. But you started with something very tangible that people can take into the workplace, and you've started to develop role models. You know, and that is critical, because without role models, without people to do further support, you're not going to get anywhere.
I wonder if I could come in there, Rebecca, following on from that and endorse that sort of skill-based teaching. We've just come back from the first Burmese Skin Initiative meeting, which happened before we were all stopped travelling. And Rebecca led a day of nurse training there, and did there were 4 powerful workshop sessions teaching the nurses how to do things. So apply emollients, take a swab and do a scraping, do wet wraps. You know, it was really, really practical. All the dermatologists who joined in, I think we all learned a lot as well, but it was the delight and the enthusiasm that the nurses were so engaged with that skill training. That really, really spoke to me that that's so much more powerful than, as you say, developing a full curriculum. And that was a real lesson to me. So, any other questions? I'm aware that we've got some people who've come off the call. I've got people texting to say they can't get on. So
yes,
don't anyone leave.
We're working on it at the moment. So it seems to be that if you leave for some reason, when you try to come back, you're placed into Zoom purgatory. So yeah, we currently have, I think, 5 people in Zoom purgatory, including Carrie Kovark and Rod Hay, among others. So we are working on it with our tech support. So all I would say is that if you do need to step away rather than leaving the meeting, please leave it on in the background and just, mute yourself, and you can hide your video, if you need to step away and use the restroom or something like that, just because it seems that if you leave, we're having a hard time adding you back in, and I'm not sure why that's true. So we're trying our best to get people out of Zoom purgatory. Who are currently in Zoom purgatory. I think Carrie Kovark is on the phone with our tech support right now. So hopefully you'll see our number go back up. My only concern is the folks that don't have a great internet connection. Unfortunately, if you get bumped off, my concern is that you may have a hard time getting back on. So I apologize. It's like a learning experience for all of us right now, given the technology. So I really, I appreciate that. And thank you so much to Julia and to Rebecca to on that really, really interesting topic. I know we did some, along with Eileen, did some nurse training in Kenya, and I think this is such an interesting and important topic. We also published a slightly relevant piece in JAMA Dermatology on task shifting, and just the concept of how can we shift tasks. So I think this is a really kind of important topic. So a couple other housekeeping issues. Yes, try not to leave unless you have to, because we may not let you back in. I apologize. I don't know why it's a one-way door. And a reminder to all before we switch to our panels that we did send out a survey, Glowderm Survey. And so in case you were not on the very beginning of our meeting, we would love for you to participate. It should not take very long. I think it took me about 6 minutes to do. It's very fast. And it is IRB approved, and it will just give us a good sense of where we want to go with GLODERM, what's really important to you, and who we are as an organization. Just because it's, we've been a bit amorphous, and so it's really nice to get a sense of really who our members are and what they're interested in, how we can best serve the group. So with that, hopefully I didn't butt in too early. Any other questions that we have? Oh, here, actually, Kasun, did you have a comment that you wanted to, Kasun Bilcher, did you have a comment?
Yeah, maybe, not really, but I just want to say we had some experience in Ethiopia, also in some parts of African countries, rather than creating a dermatology specialist nurse. Maybe it might be better to add whatever skincare or curriculum is required to the existing nursing curriculum. This makes it open for the nurses to achieve their goal of decreasing infant maternal mortality while taking care of skin disease. But we have to realize that sometimes the nurses are sometimes overwhelmed with lots of trainings also. So it might be just, I think if we, rather than giving like another specialist, then that may take away from their essential duty. So just if we add already there are like medical school, health science school curriculums for nurses, we just make sure that scabies is included in that curriculum, or wound care is included in that curriculum, and so on. I just want to say that. Thank you.
I think, Catherine, the interesting thing about Ethiopia is obviously the community skin health extension workers. I mean, they are another resource to improve skin health in the community. Yes. And I think we're all learning with these global health initiatives that we work with whoever is potentially interested or able or enthusiastic about delivering skin care wherever we are. So it'll vary in different countries depending on the available health cadre in the site we are planning on working.
Yes.
Thank you.
Yeah, you're right. Yeah.
And it's
Thank
good
you so
to
much.
see you on the call.
Yes, yeah. Yes. I can turn on the video, but let me try. It's
your photo is lovely, so it's great to see that.
Okay, great. This is one of the most recent photos also.
So
Esther, where are we? Are we thinking we might move on?
Yes, absolutely. So we're going to move on to our, thank you, Claire. So we are going to move on to our first panel. And our first panel is going to be on setting up dermatology programs in resource-limited settings. And so our first panelist, actually, Claire, is you. And so what we're going to do is give each of our panelists 5 minutes just to tell us, there's no slides, and it's just a chance for them to tell us a little bit about themselves and their work in this area. So our first panel is Claire Fuller, Toby Maurer, Tori Williams, and Margot Whitfield. And I will say, actually, Margot, just to give you the opportunity, do you want to go first since it's extremely late at night for you? Or are you, instead of Claire, we can put Claire at the end? Oh, Margot's already.
I don't mind. I'm going to be up anyway, so it's fine.
Okay. Well, Margot, do you want to go first? You can take the lead.
Sure.
Okay.
All right. So this is me. I'm just going to. So I'm sitting here with my phone pointing at me, and my laptop just next to it. So it's a bit of an unorthodox way of doing this, but that's fine. So I've been involved in Fiji, and so I'll just say, so skin diseases in the Pacific have always been regarded as a low priority despite the huge clinical morbidity that's associated with them. And like many countries where resources are scarce, dermatology has often been left behind as other medical and surgical specialties have advanced. And I heard a suggestion made about 15 years ago suggesting to create a dermatology training program in the Pacific based out of the PJ Toomey Hospital, which is the leprosy, dermatology, leprosy and TB hospital of Fiji, and it kind of stuck. And then I had an offer of about $250,000 Australian, which is about $200,000 lifetime donation, and a mentor was offered to me by an Australian man who wanted to pay back and use his project management skills. So we developed a team. He and I, we developed a team, including 4 board members with some pro bono legal advice. We set up a gift recipient status, which is a not-for-profit company. And then we ended up joining up with the only Fijian dermatologist, which is Dr. Tui Thakau. And with Tui, he was able to set up a similar charitable trust in Fiji as a conduit, really, for the money required to run the course. and do what we needed. And he's a well-respected dermatologist in Fiji who'd only been doing clinical derm work, a little bit of clinical derm work for the preceding 8 years, but who'd been involved in administration and become the permanent Secretary of Health in Fiji. So he had lots of useful contacts. And when he resigned from that position, he took up the director of the potential Pacific Dermatology Training Centre. And we worked out how to set up a course because we were aiming to try and improve dermatologist numbers because he remained the only one in the Pacific apart from PNG. So we had to raise some money. We raised a total of, in the end, about $1 million to support a minor renovation of the clinic. The skin clinic, we employed Dr. Tui half-time as a director of the training centre and employed a half-time PA for him to help get things going. So 2016 was the year it all started, and that was all about learning how to do it and making plans. 2017 was getting the clinic renovated, which ended up it was government property, so it had to go through a whole lot of committees, including the government tender board. We began the pathway towards understanding how we should do it, and we worked out that partnering with Fiji National University was going to be the way to go. 2018 was actually designing the course, getting the curriculum and going through the School of Medical Sciences, the College of Medical Sciences, and then finally the College Academic Board and the University Senate. So that was 2018. Our course was approved about December 2018, and in 2019 we'd been it's a bad word these days, but we'd been grooming people to be our first students because we had to organise scholarships for them, and we ended up with 2 from Fiji, 1 from Kiribati and 1 from Samoa as our first postgraduate diploma of dermatology students. And 2020 we've got 3 students, 2 from Fiji and 1 from Papua New Guinea. And unfortunately our doctor from the Solomon Islands, he was delayed and missed the start of the course, which in retrospect with coronavirus is probably a good thing, but he was delayed when the passport making machine was broken in the Solomon Islands, and he had to wait till the machine got broken before he could get his passport renewed, and it took too long. So 2021 we hope to have our first 3 masters, start our master's program, which has got a 1-year diploma as a prerequisite 1 year, followed by 3 years with an end exam after 2 years. And we hope to have 2 to 3 Fijians and for 2021, and hopefully 2 diploma students from somewhere else in the Pacific. And the teachers for this course is primarily Dr. Tui, who works half-time for the Ministry of Health and half-time for the Pacific Dermatology Trust, and he's paid through our company in Australia. But the other teachers last year included 5 Australian dermatologists who had their airfare and accommodation paid, but they did this pro bono, and I managed to choose people that had experience with working in this sector or had some other specific skill that we needed in order to show that we had the skills to support TUI to be able to run this course. And in addition, 3 dermatologists from Australia came to Fiji to assist with the teaching, and they paid their own airfares and accommodation. And so there's obviously some problems with this model. It requires a large number of volunteer dermatologists who are donating their time. And the goal for the Australian involvement is to train sufficient dermatologists so that Fiji will be able to take over the training program within 4 years and replace it. And replace also Dr. Tui when he chooses to retire, which will probably be in about 8 years. It's required quite a lot of work to raise the philanthropic money of a total of $1 million to get the program and cover all costs, including the dermatologists, 5 dermatologists a year, airfares and accommodation, and also a donation of lost earnings of over $1 million from the people who've donated time and lost earning monies helping carry out the course. So it's involved a lot of involvement from the Ministry of Health in Fiji. And so basically going ahead was not a one-off decision, but it ended up being a progressive one involving a lot of consultation with all the stakeholders, including the Ministry of Health, and other health departments in the region, Fiji National University, the Fiji Medical Council, Fiji Higher Education Commission, and members of the Australasian College of Dermatologists, as well as getting a little bit of grant money from AusAid, which is our Department of Foreign Affairs and Trade support for regional projects. And the training centre was officially opened by the Minister of Health in Fiji at the beginning of 2019, and its first cohort of students graduated at the end of the year with the 4 students, and we're hoping that the master's course will commence in 2021. So that's just shows one model of how to set up a regional dermatology training program. Mind you, the entire population for the 20 countries or so, or more countries that are involved in the Pacific, is going to be, including Papua New Guinea, which is the biggest, which has a total of 3 dermatologists, one of whom has a master's but doesn't have a diploma, and she's the one who was there and is actually trying to get out of Fiji today to go back home to PNG, but she can't get back. So it's been a challenging kind of episode over a period of time. So
thank you, Margot. That's amazing.
That's a model, but the population, total population, is going to end up being something like 15 million. So the numbers across those 30 countries is relatively small when you compare that to the African population, but not insignificant. Fiji's got less than 1 million people, and they're going to be the leaders in the Pacific. They're the leaders of the Pacific financially and educationally.
Wow. Well, Margot, 3 cheers, and thank you for all that effort. It's just a huge program. And if you'd be willing, Margot, to put in the chat feature, you have the Skin Fiji Facebook page. Did you have a website for the overall training program that you'd be willing to share?
Yeah, we do have a website. I will put it on the chat page.
That sounds perfect, so people can take a look. And I apologize for not introducing you properly, Margot. I apologize. We've been dealing with some technical issues with people that have been dropped off. But I should have said Margot is Australian, as those of you who don't know her probably figured out, and has been working in the Pacific for 20 years and involved in clinic work, scabies research, and albinism activism, and most recently has set up this postgraduate diploma in dermatology and a 4 years master's in medicine in Fiji. So I apologize for giving you the introduction afterward, but thank you so much, Margot. Does anyone have any questions for Margot before we move on to our next panelist? If so, you can put them into the chat feature, or you can just unmute yourself. Hearing none, then we will move along to our next panelist in this topic, which is again looking at setting up different dermatology programs in limited resource settings. Why don't we, Claire, we'll have you at the end, so why don't we move on to Toby Maurer next. And thank you so much, Margot.
Hi, thank you very much. I'm Toby Maurer. I have recently joined AMPATH, which is run through Moy University and Indiana University as a consortium of 10 North American universities in partnership with Moy. Previous to this, I worked also in Uganda with UCSF and the Infectious Disease Institute. Because of the work that I have been doing, mostly research work through HIV/AIDS, I saw the need, as many of us have seen, to put together a teaching program of dermatology both in Kenya and Uganda. Of course, we've always had the benefit of the regional training center, teaching center in Tanzania and Moshi. And many of our Kenyans and Ugandans who wanted training in dermatology went to the RDTC. Sometimes that had worked out, but oftentimes it was very difficult for those trainees to continue their training only because it required that Kenyans and Ugandans left their home country to live in Tanzania for 4 to 5 years. Some of us have had the benefit of that. Dr. Caprano, for example, in Kenya, did that program, came back to Kenya, and is one of our key participants in the training program. But again, the desire was to really set up training programs, individual training programs in Uganda and in Kenya. And so in Kenya, we went forward and worked again at Moi University, and in Uganda at Makerere University to try to set this up. Margot and I have had a personal challenge to, or shall we say a competition to see who would actually get some trainees out with all this work that's been going on for years, and Margot has won out, no question. I'm about to tell you about some of the challenges that we've had in trying to put together these 2 other training programs. First of all, just the rationale that we used for setting up a derm training program. I think many of us in GLODERM on this call in particular have done training programs in the past with many of our African colleagues. What the concentration has been, however, has been to really get people out quickly, to train people within a couple of years for some of the more typical derm problems that Julie brought up, training people on scabies, training people on some of the more common things. The goal of the training program in Kenya and Uganda was to really put up residency training programs like we have in various countries, in the United States, in Canada, in the UK, in South Africa, to make these full-on training programs, what we call M-Med programs, which is a 4 to 5 year training program of dermatology, really training our persons, to our doctors, to become full-on dermatologists, to be able to tackle some of the many challenging dermatologic problems that we see throughout Africa. So the reason behind that, again, is to really keep the field of dermatology up to its highest level, and to keep research going, and to really keep our field at its highest level, not just barefoot medicine, but to really tackle the problems that we know exist and for which we have very limited training at the present time. So with that, we've put together these programs. The idea is to have a sustainable program. I think Margot brought up the question of who can teach in these programs and how do you sustain them. Margot's programs have really relied on volunteers. The programs that we're trying to set up in Kenya and Uganda do not rely on volunteers. We hope to tap many of you who are even on this call to work in those programs, to come to teach 2 to 4 weeks a year, and to be paid. And how do we pay? Well, yes, we're trying to raise philanthropic money, donations, so that we can pay you to teach. But as Margot pointed out, that costs about $1 million for a 4-year program. I am trying to raise money by providing services in our North American programs. And those services are teledermatology services that will raise money for payment. Some of that money will be used in the global programs to support the global programs. And I can speak longer on that at some point, probably offline, for anyone who wants to know how to raise that money through teledermatology contracts. But the point is, I think there is a need when you're thinking about training programs, to think about how you will have faculty, at least initially, that are probably distributed around the world who need to be released from their own training programs. How do you pay them? How do you get them to where they need to be? And how do you sustain them? So that has been a big problem. And we're moving towards that.
Toby, there's a couple of questions from the group before we move on.
Sure.
2 questions, and then maybe you'd be willing to take them. So one is from John Storwasser asking about the Mbarara program. I think you can see it possibly in the chat feature. So he asks, when I was last in Mbarara, I met with Grace Yoa and also the Dean of the Medical College, and it seemed to be well run. And could you comment on the status of the Mbarara program?
The Mbarara program continues to go on, and thank you for asking that. It is a program that is run by Dr. Grace, who has been doing this for probably 15 years. Again, has people coming in and out through volunteerism, mostly through our HBO programs, coming in and doing some special teaching. And that has been a good program. It really takes people from around Uganda and other countries and teaches them for several years, sometimes 2 years, sometimes 3 years, or sometimes 4 years. Not very standardized teaching, and it's hit and miss. It depends on who's there at what time and who can volunteer. Again, what we were trying to do in Kenya and Uganda at Makerere University is to really get a full-on MEd program with degrees and certification recognized by the Ministry of Health and the Ministry of Education, so that these people can go out into the community and be full-on professionals and also sustain a future academic program at these particular universities.
Thank you, Toby. We have a couple more questions from the field if you're willing, and I don't know who asked this one just because it came from iPhone 2. But a question is, we're wondering, doctors who undergo MEd training, do they get certification after the training? And if so, is that recognized internationally?
Yes, thank you for asking that question. The MEd programs are being recognized in Uganda and Kenya. And as I just said, these are being recognized at the highest levels of government. So these are not just under the table, a couple of trainees out there who kind of have random training, but it is being recognized by government to have standard training at its highest level so that these people can become not only wonderful practitioners and standardized to world standards, but also can be the leaders in their own academic programs, which we hope will be sustainable over the next 20 and 30 years. That's the idea. Will this be recognized internationally? You bet. Again, that's the reason and the rationale behind really developing MEd programs to the highest level. We want our practitioners who graduated from these programs to be at the standard of South African dermatologists, UK dermatologists, Philippine dermatologists, dermatologists around the world, so that we can continue to work together to get the field up to its standard and to be recognized internationally.
And Toby, we have another question from Tanya Tran, who works in Vietnam and also in Boston. And she asks, could you tell us more detail about how to raise money from Telederm that can go towards philanthropic efforts?
Thank you for that question. It has been our experience, certainly in the San Francisco Bay Area, that we can really have teledermatology services supported by government, mostly for our underserved patients. So if you will, we're trying to work teledermatology for underserved patients in our local environment, being paid through contracts by government So the government pays us to develop programs to continue services to our underserved. We get a contract. From that contract, a certain portion of money is put aside for global dermatology. And that pays to release our professors who are in our academic institutions. It pays for them to leave their posts and go teach in Kenya and Uganda. I always think of dermatology as being both a blessing and a curse. We as dermatologists at academic centers, we bring in a lot of money, which is great, but our administrators don't want to lose us, and they don't want to lose us in our posts. And so we have to pay, or we have to come up with an idea for release money so that we can be released from our posts to go teach at these various programs.
I've always been very impressed, Toby, at your very creative ways of getting people to have time to do this, because I think it is so important. Thank you. Did you have any final points you wanted to make before we moved on? We had some great discussion from the group.
Just one point, which is through these challenges, one of the biggest challenges of getting a MED program up and fully recognized by government is that you have to embrace the government regulations. And regulatory has been one of our hardest challenges. And I'm sure Margot has also encountered this. Regulatory is a real bear. We are working through this. I think we will learn regulatory, or how to get around regulatory challenges actually through this coronavirus crisis that we're in. I think we'll probably loosen some of the regulatory challenges that we have seen. But one of the ways of at least keeping up the pressure, regulatory can take down all of these academic programs in one fell swoop. And many of us lose heart because we can't stand dealing with the government and the regulatory. But keep it going. And one way to keep the pressure going is to actually put together dermatology clinics. And I think, Margot, you have done a terrific job of that. Create and build those dermatology clinics, even without the MED programs being given final permissions, so that government can see the need for the dermatology clinics. If you build the clinics, patients will come and government will get the clue that we need more doctors in dermatology and that we need adequate and appropriate training. That's my only last point there.
Can I make one last point?
Yes.
Yeah, go right ahead, Margot.
I was just going to say the regulatory things were really important for doing that. We actually designed a program which won't qualify the graduates to become dermatologists in Australia because of the difference in money that's available if those doctors come to Australia to become dermatologists. So we elected not to include so much skin cancer work. We elected not to have cosmetics. We don't teach about how to use biologics. We need to learn the science of biologics, but they're never going to be able to use those medications in that country because a $20,000 a year will just about support the entire dermatology department. And so we had to make that separate, but we did have to design a course which would mean that the graduates would be recognised as a specialist within the country. And the last visit that we went was meeting with government because we discovered that in order, they've already, and the Scabies has probably helped for the government to realise that dermatology is important, and they have to put it at their high level of need, and that will allow scholarships to be granted because all the countries which provide scholarships for trainees to do these courses depend on what the government's priorities are for education at that time. And then we discovered that the way we have to, they just have designed a 10-year strategic plan. And so as part of that, we had to go and talk to them about their strategic plan, is that they're planning to employ more dermatologists in 5 years, because there's no point graduating a dermatologist when the only job is within the ministry, because there is no private sector work. So you have to convince the ministry that they're going to create positions for dermatologists so that the people who are doing the courses will actually want to become dermatologists. So it's very complicated.
Thank you for that. Thank you. Well, thank you very much, Toby and Margot, for your input. I think that's really, really helpful to hear. And I know there's been a number of roadblocks, but I think you've really triumphed over a lot of a lot. I think it's, yeah, I think one thing that's going to be very challenging for all of us is to see how all of these training programs are going to be affected by COVID-19, and to really try to, as you said, perhaps this is a way to break down some barriers, you know, in terms of the intense kind of regulation that we're dealing with. So thank you. Next, I'd like to invite Tori Williams to speak about her experience. And Tori is based at UPenn, but has been, for the past year, she's currently back at Penn, but for the year before that had been living in Botswana. Tori, give me 1 second. I'm going to change the video over to you. Give me 1 sec.
Hi. So I knew we were going to have some other fabulous speakers kind of focusing more on the training programs on the local side. So I wanted to talk about the flip side of trying to develop global health training in developed countries for our residents and trainees and faculty who, you know, it's really an important goal to try to get dermatologists everywhere to have a more global mindset so that they can practice in a way that's more culturally compassionate and culturally competent. And so the way to do that is sort of build global health opportunities into residency training programs in developed countries. And one model for that has been the Resident International Grant through the American Academy of Dermatology. So myself, along with Carrie Kaverick and Dr. Amy Forrestal and others over the years, have helped to direct this as an amazing opportunity for residents to gain experience. And the program has been, for the past 10 years, last year we celebrated our 10-year anniversary, yay, of this program. And it has been primarily based in Botswana through the Botswana UPenn partnership. And for people who are wanting to build global health opportunities into their training programs at their institutions, one of the biggest tips or advice that I want to offer you is that when you're setting up programs, over time, you're going to need to reassess and be flexible to the changing needs of both your trainees and to the sites that you're working with. It's important to adjust to ensure that everyone's benefiting over time. And so I want to talk to you about our experience in Botswana as sort of an example of how we changed over time. So whenever this program initially started, it was in response to the severe HIV epidemic that was really raging in Botswana in the 2000s. And the Botswana UPenn partnership started working there and really focusing on HIV care. And then people realized that there was a huge burden of skin disease for patients with HIV, and there weren't any dermatologists there at the time, anyone formally trained giving care. So the Resident International Grant was developed by tremendous work from Carrie Kaverick and others in the support of the AAD to bring residents into Botswana, dermatology residents, to fill a gap in care. So to fill in this dermatology care that wasn't available locally, and through a system of overlapping dermatology residents who have been basically coming almost, you know, pretty consistently over the past 10 years, offering the sustainable source of care that wouldn't otherwise be available. It's been hugely important to the public healthcare system in Botswana. So Botswana doesn't have a local dermatology training program. They don't have a dermatologist or dermatology department in their any academic institution. So what they have is just dermatology clinics that are at you know, public hospital. So with the residents visiting, they're able to offer patient care and also offer teaching to local physicians and nurses. So that's been a way to build up dermatology capacity. And over time, we are excited to say that we've been able to build capacity enough to where we actually have 5 dermatologists working in the country now. And so they don't actually need to have the constant support from visiting dermatology residents. So what we're realizing is that it's best for the local system if we now sort of step back and pull back with the Resident International Grant and give them space to sort of build up their own preferences and how they're going to run their local system. So this past year, we've made a major shift in expanding and changing the Resident International Grant program to only send residents to Botswana for half of the year. And then for the second half of the year, we've decided to expand the program to 3 new sites. And this is going to offer new learning opportunities. And the new sites are going to be in Durban, South Africa at the University of KwaZulu-Natal, in Lima, Peru at Cayetano Heredia University, which is in association with the Alexander von Humboldt Institute of Tropical Medicine, which a lot of you know is where the Gorgas course in tropical medicine takes place. And then also in Dhulikhel, Nepal, at Dhulikhel Hospital, which is a branch of Kathmandu University, which is located just outside Kathmandu. So the difference in sending residents to these locations is that these are very well-established dermatology departments with residency training programs. So this is going to offer residents a very different learning experience. So they're going to learn from local dermatology experts. It's now going to be possible for any level of experience dermatology residents to apply, where previously for the Resident International Grant, we really only wanted senior dermatology residents who had a lot of global health experience and were very comfortable working independently. So now this new expansion of the program allows for more people to have opportunities for this grant, and it's really going to open up opportunities for more collaborative bidirectional learning between programs. And what I'm most excited to say is that the grant is now going to be offered to residents at these international sites. So they're going to have the opportunity to rotate at a U.S. dermatology institution. And that really is the goal with all of these training programs, is to make sure at both sites people are having opportunities for learning, and that it's benefiting everyone, which I think is so important in global health. So I want to let everyone know about these changes, and the applications for the Resident International Grant are now open. And this is going to be for the Botswana Rotation, which we are now doing each year from January through June. And like I said, that's more geared towards senior level dermatology residents who have global health experience. Applications are going to be due the first week of April. So we're extending them a little bit due to all the stress on our departments right now. And then in September, that's when we'll be accepting the next round of applications for the new sites in South Africa, Peru, and Nepal. And those rotations are going to occur each year between June through November. And I know all these dates are confusing. All the information is listed on the AAD's website. I'll put it in the chat, the link to that, so that people can have that information. And this opportunity is open to all North American residents, dermatology residents, and I think it's a great way to incorporate some global health training into your program.
Fabulous. Thank you so much. Real and virtual applause for not just the talk, but all of the efforts. Any questions for Tori before we move on? I know there's a lot of, okay, here we go. Let me see how we can manage this. Hold on one second. Got too much on
So
this.
actually, the question is about really something that will come towards our business section a little bit later on. So thanks for that, and we can pick that up later. So
great, thank you, Claire.
That's great. Yeah.
And for reasons of time, we are going to, Claire has very kindly agreed to kind of skip over as a panelist, because you'll have a chance to hear from both her and myself a little bit later on. So we're going to move on to our next panel. And we have unfortunately lost Helmut Bertranelli, who's going to be one of our next panelists due to another meeting. So I'd like to move on and invite Sarah Coates, if you are available. I'm just going to send you a little starting video. I'm going to unmute you. Sarah, are you with us?
Yes. Can everyone hear me?
Yeah, let me put the video in. You give me 1 second, Sarah. Apologize, this is a learning process for me. Give me a moment.
And just while you're doing that, David, who's been assisting us with bits and pieces, is meanwhile trying to get some people who are out there in the ether not able to join us. So there are some teething problems with this, but I think in general, we've got about 60 people on the call, and all the comments, many of us are participating, but it's not completely perfect, but it's not damn bad either.
Yeah.
So
definitely. And so we do, I think I've managed to spotlight your video there, Sarah. And I will say, I did hear from Carrie Kovarek that she was able to get back on. So I know we've gotten some of the people that we lost back on, but it's a little bit of a learning curve for all of us. So Sarah, I'd like to turn over to Sarah. Sarah has actually just returned in the last few days from Kenya, where she's spending the year as a Fogarty Fellow. So I'll turn it over, and actually we're kind of changing topics in terms of our panel. And so the last panel was really about setting up international derm programs. And the next piece, I think, is going to get to one of our audience members' questions about kind of as a trainee, what are the options? Is we really wanted to talk a little bit more from a career development perspective on how do you fit global health dermatology into your career. And so we wanted to give you a sample to hear from a couple different people who've done this in different ways. So I'm going to turn over to Sarah to tell us a little bit about herself and her plans.
Thank you, Esther. So hi, everyone. I'm Sarah Coates. I am a new dermatologist. I just graduated from training at University of California, San Francisco. And as Esther alluded to, my global health work is based in East Africa. So I want to give you a sense of my pathway and some of the observations along the way that helped me get to the next level of my career. So I started working in East Africa and Tanzania when I was between my first and second year of medical school. At that time, I spent 3 months working at the Regional Dermatology Training Center in Moshi, Tanzania. And I know that many people on this call have been leaders there, have visited there, have worked there. So I thank you for that. While I was there, mainly what I was focused on was patient outreach, including skin cancer screenings and patient education for patients who had oculocutaneous albinism. So there was a little bit of a focus, but it was not research centric. It was actually my first trip out of the country. And it was a really good chance to wet my feet and see what I thought about it. It was also an introduction to the role of dermatology in global health. There were very limited opportunities to pursue dermatology specifically at that time that I had been aware of. A couple of years later, because I enjoyed that experience so much, between third and fourth year, I did a research gap year. And during that time, I divided time between New York, where I was in medical school, and Mwanza, Tanzania, so returning to the same country, but slightly different city. The goal of that research was to build a sustained telederm connection between primary care physicians there and dermatologists at Cornell, where I was in medical school. I think my snapshot from that experience is it was quite informal in the sense that I designed the year myself and secured a modicum of funding to cover basic expenses. And that was thanks to the gracious support of Dr. Granstein, who was the chair of the Cornell department, but was not global health oriented at all, and had never been to the site that I was working at. So it was really nice of him to take a chance on me, but at the time, there were not many opportunities I was aware of to do formal research in that setting. And so that just speaks to some of how far we've come in many ways, but also some opportunities for continued growth. I was really lucky to get to train at UCSF in San Francisco for residency. I chose my training environment with global health in mind. There were several HIV and global health focused dermatologists like Toby Maurer, Kieran Leslie, Aaron Amerson. And so that really drew me to that setting. When I was a second year resident through Toby's mentorship, I applied for a Women's Derm Society 1 month research elective, and they sponsored me to go to Kenya for the first time and do a 1 month elective at that site. And that was kind of a chance to see what it would be like to work there for a longer period of time. It was also a chance to see what global health work would feel like once I had completed most of my training, which was very different from being a medical student. I also want to say that I had a chance to participate in ongoing efforts led by Eileen Chang, who you've heard from, as well as Toby, who you've also heard from, in their efforts to start a dermatology training program, which was really a model of global health dermatology that I was most excited about in terms of building capacity through formal training. And so based on all of that, I decided to apply for a Fogarty Fellowship through the University of California Consortium. I should say Eileen was actually the first dermatologist to receive a Fogarty Fellowship. I was the second, as far as I know. And it was a lot of her leadership and friendship that helped illuminate that path, and Toby's mentorship. So I was really lucky to get that grant. I have spent the last year traveling back and forth between Kenya and Uganda. My project focuses on Kaposi sarcoma, which I'm happy to talk in detail about as needed. But I think more broadly, it's been an opportunity to think about other derm areas of need, including severe cutaneous adverse drug reactions, which I'm working closely with Eileen to help improve in our setting. I would also say, just for those interested in applying for a Fogarty, it's a really formal and structured program, which is different than anything I've been able to do up until this point. And that's been really vital to help me guide, as an early career dermatologist, my career path. I've really appreciated the formal mentorship and the formal structure of the program, and it's really taken it to the next level in terms of helping me think about what the next steps would be to be able to do this long term. So I timed myself, that's 5 minutes. I want to pause and leave room for questions or any areas of clarification.
Well, thanks very much, Sarah. That's absolutely brilliant, and just what we wanted, just a little snapshot. And we've also got Eileen, who's the other Fogarty Fellow, to be able to just see, particularly perhaps now a little bit later on, how she fits global health into her career, another example. So Esther, I might need you to do the clever bit and get Eileen's face back on, because that will be quite beyond. And we had actually hoped to have Helmut Beltrinelli, who set up the, or has worked in Africa, establishing the dermatopathology training, having done 6 months, and how he's continued to do that. So it's a sort of different experience. So but obviously COVID's claimed him, well, hopefully not completely, but just transiently. And we look forward to Eileen. So away you go, Eileen.
Thanks. Oh, can everyone hear me?
Yeah.
Yeah, okay. So similar to Sarah, I thought I would just focus a little bit on my motivations for dermatology global health and some of the opportunities that I've been took advantage of as a trainee. And then I'd also like to give you the perspective of someone who's 2.5 years into being faculty and what kind of my career trajectory is looking like right now. So my interest in global health developed well before my interest in dermatology. When I was in college, I taught a global health seminar, and I kind of knew that this was kind of my interest leading me towards medicine, was global health. When I was a medical student, after my first year, I spent a summer in Beijing where I did research on Sjogren syndrome. And that was kind of my first foray into actually being on the ground in a sort of developing context. Though I will mention that the medical system in China is quite developed. But in terms of exposure to sort of more of the socioeconomic and social determinants of health, that was a new exposure for me at that time. And so I knew that I had this global health interest, and then, oh man, then I got interested in derm, and I was like, how does this fit? And then luckily I met Carrie Koverick, who has been an incredible mentor to me, and I met her as a medical student. She offered me a lot of independence and ability to explore my interest. And through my time in Botswana, I really saw that there was a huge need and a huge overlap between dermatology and global health, and that clearly there was a way for me to blend these two interests. And so as I was, I took a year out in medical school to do research, and I had projects going on in both Botswana as well as in the US. And then when it came time to think about residency programs, I wanted to be at Penn for a whole number of reasons, but one of the main ones was that I wanted more time during residency to be able to explore my global health interests, and Penn had a very generous elective schedule throughout residency, first year, second year, and third year, so I was able to take advantage of that. And so Tori talked about the Resident International Grant, and so I was able to take advantage of that and go to Botswana for a month. Through the Women's Derm Society Mentorship Award that Sarah also mentioned, I went to Jipmer in South India for about a month, and in that setting just was immersed in this incredible academic environment, and I learned so much, particularly with respect to skin presentations and darker skin types, and also looking at a pretty high functioning academic dermatology department in a developing context. And that was really just opened my eyes to the possibilities. I also took advantage of the AAD Native American Health Services Rotation, where I spent a week in Chinle in Navajo Nation. And that was a really pivotal 1 week. Like, it went by really fast, but I still look back on that 1 week so much. And I think the reason for that is that it drew my attention to the gross inequity in healthcare that exists in our country. And that has really stayed with me and shaped my career moving forward. That said, throughout residency, I knew that I wanted to have a sort of longer term experience in a low and middle income country setting. And so I was pretty dead set on figuring out what that was going to be. And fortunately, everything lined up. I met Toby, I applied for the Fogarty, they took a chance on me. I will just tell you that I was initially waitlisted, which was really tough, but the opportunity came up to kind of reapply, and I did that, and I'm so grateful to have had that experience. My Fogarty year was absolutely amazing and really career affirming for me. I guess I can talk a little bit more about Fogarty if we have like a question and answer panel session, and Sarah can as well. But I've completely forgot to time myself. I have no idea how much time I have left, but I will just take maybe a couple minutes to tell you about where I am now. I am at University of California in San Francisco, and I'm based at San Francisco General Hospital, Zuckerberg San Francisco General. And a lot of my work is primarily focused on scabies at this point, and I have a particular interest in migrant populations. So I've done some advising with MSF around scabies control in the detention centers. I'm advising an NGO that's working at the US-Mexico border. I'm collaborating with UNHCR and IOM in a Malawi refugee camp to address their scabies problem there that extends into their local communities. And I'm also really excited to be collaborating with the Research Triangle Institute out of Durham to look at how scabies can be integrated into NTD programs. I've also taken care of a large population of persons experiencing homelessness, have seen the parallels between scabies and lice infestation. So I'm taking a lot of what I've learned from the scabies world and bringing it to our population in San Francisco, and now working towards clinical protocols to minimize unnecessary use of permethrin because people are incorrectly diagnosed as having scabies, and evaluate the role of ivermectin in treating lice infestation. And in addition to this, I still have ongoing work on wound care, and Sarah mentioned this AfriScar project in Kenya. So I think I'll stop talking for now.
Well,
thank you very much.
Thank you very much, Eileen. So I just wanted to, we really appreciate the opportunity to hear about this, and to say we did post the information on the side for the Fogarty for people who want to read about it. I'm sure you can reach out to Sarah and to Eileen individually as well. Sarah and Eileen, if you're willing to maybe put your email addresses up there for folks to see if they can reach out to you. We are very happy that we have a new Fogarty Fellow for next year, Sigrid Collier, who's also on the phone now. And she will be based in Kenya, and she's coming from University of Washington. So it certainly seems like a particularly great way for people to kind of have that protected time to really invest time in another setting. I am going to finish up with this panel just because I do want enough time for our business meeting. And I do want to take actually a moment to do a very unusual group photo. before we launch into our business meeting, which is that I think this is the way forward for now, at least for the next few months for all of us. So I'm going to put you on gallery view. And so if people are willing to turn on their video for a moment, I'm going to take a screenshot of all of us. And that this is, I love it. John's got his mask around his neck. So I'm going to take a moment and just take a screenshot here. All right, here we go.
I love this. I love the scuttling around as people try and get into frame.
Fantastic. You guys all look beautiful. We're going to do one more. All right, everyone. 1, 2, 3, smile. All right, beautiful. I think we captured it. Everyone else is smiling. I look very weird, but I'll take it.
While you're doing that, I'll do page 2 and page 3 while you're chatting. So.
Oh, good. Okay, Claire, if you can take more of them.
Yeah.
Let me try one. It's actually surprisingly hard to talk and do this at the same time. So thank you. This is the modern way forward. So I appreciate everyone. All right, I'm going to do one more picture of us, and then I will launch right into our. Let's see, 1 second, and take one last. All right, you guys are all beautiful. Thank you so much. So that's lovely. All right, I'm just going to save that, and then we are all set. Well, thank you for that. I wanted to move on to our business meeting. Initially, I can just give you one sentence version of myself. I think I was supposed to be a panelist on this, and I'll just say that what I always like to tell my students and my trainees is that there are so many different ways to include global health in your career. And so these are just kind of a couple little snippets. And so I just, I think about even just the people that I know that are doing this. So my pathway, for example, is I am a research scientist. So I'm an MD, PhD trained epidemiologist. I do 20% clinic and 80% research. And so my efforts in global health dermatology and research are almost entirely funded through the National Institutes of Health, through competitive grants, for example, K23, which is a career development award that can be used internationally and domestically. So I think research is one pathway. I know that Carrie Kovarik, and I'm not sure if she's back on the phone, has a different pathway that she's done with dermatopathology. I know that Claire, who's running several international organizations, does it through a different pathway. So I think one thing I just want to express to especially our trainees on the phone, that there is no one path. I've always viewed global health dermatology as a choose your own adventure. And so I think one thing we would like to have more time, and ideally we would have a much longer in-person meeting, but in our short brief time today, just to say, please feel free to reach out to any of us to kind of discuss our different career paths, whether you are more of a research focused person, or if you're more of a clinical care focused person, or if you're more of an education focused person. I think there is room for all of us. And I know with Helmut, who is also supposed to be on the panel but had to leave due to COVID, he's been working with programs at Moshi, and he's a dermatopathologist. He's based in Switzerland and spends, most of his time in Switzerland, but some time in sub-Saharan Africa as well. And so I just wanted to just make the point for the trainees on the phone, and particularly that there are so many different pathways. And I think that you can be very creative with how you involve global health dermatology. So that was the point that I kind of wanted to make. And I do see there's a couple of comments before we quickly move on to our business meeting. So are there faculty, so one person asked, are there faculty from GLODERM on this conference who are taking med students on for a research year? I think that's a great question. So I myself do take on students for a year. I prefer to have fellows for a full year just because of the investment of time and effort. So what I would suggest, overall, I think there are actually quite a number of us that take students for a full year. I think Carrie Kovarik takes students. I know Toby tends to take students for a year. So what I will say, probably the easiest way to respond to this is if you are faculty and you do take students for a year, if you're willing to just post in the chat feature. And then one other thing is that we are continually working on updating the GLODERM website and really creating this virtual community. So I think that one thing we will be doing over time is really creating more of a list of mentors and people that you can reach out to. And so I would encourage you, if you are filling out the Glowderm Survey, another little shout out, we've already had like 30 people respond, so thank you. If you are filling out the Glowderm Survey and you are a student or a trainee and you are interested in mentorship opportunities, I think that's one thing we'd like to hear from you, because that's certainly something that myself, when I was a student, that I really would have loved. I think it was harder to find people, and one of our major goals of GLODERM is to be able to have people in one place, so that they can, it's much easier to reach these opportunities. So Chinwe asks as well, are there opportunities for global dermatology fellowship training? So right now, I will say, I think most of us have kind of an informal fellowship. I myself take students at different time points. So for example, and trainees, I should say, at different time points. So I tend to have some medical students, and then potentially people who are at different levels of training. And then next year I'll have Sigrid, who's actually a faculty member. So I think we do have opportunities at different levels. I don't know right now of a formalized global health dermatology fellowship. And Claire or Toby, I'll open it to you. I think people thus far have been doing it a little bit more informally, but I think it's something we're all working towards.
I think it's pretty informal. That there's nothing I know of that's definitely happening, although there is, as you say, people finding their way and being creative, and some of us are mentoring unofficially. But I'm hoping that GLODERM exactly will provide more concentrated, formal collaboration, and this is something we'll come up to. Sorry, there's a bit of interference. I don't know where that's coming from, but yeah.
And
Toby, I don't know whether you want to add.
I would just say that we have a Derm Path Fellowship at Indiana University for next year, which we hope to continue on. And we're taking a young trainee, finished dermatology from Tajikistan. So stay tuned to that. I think our Derm Path fellowships are available again throughout Europe and certainly in Switzerland. So that's something to think about. And then we're hoping that we can keep pushing fellowships, formal or informal, through AMPATH, through Kenya and the affiliated North American universities. And so people can jump on to that. Of course, we're all a little shaken by coronavirus, and we don't actually know what will be happening and when that will be happening in the future. So hold on, but certainly let's inquire amongst each other and through this GLODERM that we can maybe continue to make these inquiries and at least know who's interested and start placing people.
And I also wanted to address an earlier question asked by one of our residents at the UVA, who's talking about people starting to have a global health curriculum. I think that segues nicely into a component of our business meeting. I actually wanted to turn it over to Claire and I apologize for the little bit of feedback we're getting. I wanted to turn it over to Claire to talk a little bit about a transition that we're having in GLODERM that we'd love to get all of your approval for, that I think is going to make it a lot easier for us to connect people with different opportunities. So Claire, do you mind if I turn it over to you?
Yes, thank you so much. So this is an offer from the International Foundation for Dermatology with the humanitarian arm, or the resource poor arm, of the International League of Dermatological Societies. And we consider that GLODERM, building a capacity within GLODERM, developing GLODERM, is a really key part of our strategy to be more effective as undertaking projects and expanding our reach into improving skin health in resource poor settings, resource limited settings, wherever those may be. So we have secured enthusiasm from the ILDS board to offer to support the infrastructure development of GLODERM. And that would look like providing some secretarial or infrastructure support, supporting the regular leadership meetings, which we've been having very sporadically up until now because it's all been very volunteer based, and also supporting the annual meeting and getting that organised and pushing that forward. So those will be the first things. The commitment would be for a period of time, maybe say 3 to 5 years, and then be reviewed. So it's not ongoing, unconditional support forever, but it's something that we feel very passionate about supporting the development of GLODERM. Obviously, I'm completely committed to GLODERM myself personally, but with my other hat on as IFD Chair, and with my amazing committee that I've got at the moment, an amazing team at the ILDS, they also see this as a really key outreach and initiative that we want to see grow and flourish in order to provide the worker bees to be able to do the projects that we think are really, really important for global health dermatology. So we didn't want to just muscle in and say this is what we were doing. We wanted to reach out to you and ask for your approval, because you may see some concerns about this, but it would be a temporary commitment, and we'd be really pleased if you were wanting to approve this, to press on with kind of crystallizing what that actually might look like and what we're actually offering.
Thank you, Claire. This is really huge for us. And what I would ask our membership that are currently online, if you could please put into the chat feature, if you can just say, I approve or I agree, that would be very helpful for us, so we can get a little bit of a quorum. That would be extremely helpful.
I think if you don't approve, actually, and why not, would also be really, really helpful. So do feel free to say that. I've got quite the thick skin, not terribly thick skin, but I have got quite a thick skin.
And in particular, I will say this is, for me personally as well, it just would be really huge for us, because I think of GLODERM as a very proud, slightly garage band operation. In that we are kind of a band of volunteers that are just doing this in our free time. And I think to be able to really grow as an organization and to serve, I think some of the questions that were coming in from our trainees in particular of how do we connect better, I think having some administrative support is really going to be hugely helpful to us in order to achieve that mission. Now that I've really laid it on, now you have to really disagree with me and Claire. Sorry. But if people do have concerns, it's actually a very reasonable, we would love to hear them.
Sure. Do we want to move on to
let's move on.
Vienna? Do we want to talk about our next meetings?
Exactly. Thank you, Claire. I'd like to just put on everyone's calendar, save the date. So the EADV, which, Claire, what does it stand for? European
Academy of Dermatovenereology.
Thank you. So the EADV will be happening in the end of October. I believe it's the last weekend in October. So I would like to put on everyone's save the dates that we are hoping to have a GLODERM meeting at the EADV, probably towards the beginning of the EADV. So we will put the dates in the chat feature, actually, just so you have the specific dates. But I would ask that you would save the date. The other thing we will be discussing at that time and starting to think about discussing as we lead up to it is a change in leadership. So I've been chairing GLODERM now for 2 years. Well, not as of right now, but as of the fall, it will be 2 years. And so we'd previously agreed that our current leadership structure would be reevaluated after 2 years. We potentially have a new set of elections. In particular, I think some things that our European, especially colleagues and colleagues from other countries have brought up is that we want to make sure to be a truly global organization, that we are not too Amerocentric. And so one possibility is that we may be transitioning to a leadership structure where leadership rotates between different continents and different parts of the world over time, which I think is a great idea. So I'll just suggest that people kind of put their thinking caps on. Please put the EADV dates in your diary so that you could join us there. I think it would be a really important meeting, and that we'll start thinking about our leadership transition plans. And to particularly give a huge shout out to Claire for everything that she's done, that we literally would not have been able to do any of this without her. So, extremely.
Well, I think, Esther, we're a mutually admiring double act. So, I think that's great. And I think worth following on from that. So, and then the subsequent meeting to that would be in Australia, in Melbourne, at the International Congress of Dermatology, which is run by the International Society of Dermatology. That'll be in November 2021. So that's another thing to put in the diary. And we've even got a meeting room for
we
that.
have a room.
So we have
a
room, absolutely. So we have the intentionality declared to rotate the meetings to different continents each time. And when we look at the current list of members, it's way more Americans involved at the moment. And so I would ask anyone who's currently on this call or even gets a look at this chat stuff is to reach out to every other continent to make sure that the dermatologists who should be included, who may not know about it, we really encourage them to join, just so that we're truly inclusive and truly international.
Yeah, thank you very much for that point. Yeah, and so we're delighted that we have at least 2 meetings kind of on the books, both in terms of EADV and Australia. I think, and so we mentioned the leadership transition. I'm just looking at my list here. And I think the last thing I just wanted to do one more final shout out was for our GLODERM Quality Improvement Project, which the survey went out to. So we'd really love to hear about folks and what they're looking for from GLODERM and how we can best serve you. Other future projects that we really would like to do would be to develop an interactive map, for example, that would allow you to see where people are working. You might be working near someone and not realize it. And you know, it'd be nice to be able to interact more with both our trainees and other faculty members. So with that, I would say I would love to draw our second annual meeting and our first ever virtual meeting to a close. I will hand it over. Claire, did you have any last points to make before we?
Well, really just to thank everybody for their enthusiasm and for staying connected all this time and for joining us. It's really immensely encouraging. And I'd particularly like to thank David for all he's been doing in the background to try and connect some people. And obviously, it's a shame we haven't got everybody on that was trying, but thank you to David for his efforts. And thank you to Esther and Toby and everyone who's been involved, and our super speakers, Eileen and Julia, so much for doing our first virtual online meeting. It's really, really significant. Thank you also to the panel members, to Sarah and to Tori and to Margot, and particularly to Margot for staying up all night. And I can still see Stephen Shumack's on the line, and he's also in Sydney. So such dedication, and thank you to you all.
Yeah, we really appreciate it. Thank you. You know, we don't know when we put this on if 10 people are going to show up, and all of you came big time. So, you know, we really appreciate it, and to have so many people joining us from so many different places. So we look forward to the next one, and hopefully in person in Vienna. If not, we will all be on Zoom again.
Thank you very much. Yeah.
Thank you, everyone.
Goodbye.
Bye.
Bye.